Good afternoon, ladies and gentlemen, and welcome to this side event on risk communication, community engagement, and infodemic management. We are going to look together at how RCCE-IM, which is the way we call it, can save life. My name is Cristiana Salvi, and I'm working for the WHO Regional Office for Europe in Copenhagen, and I'm in charge of this area of work in the context of health emergencies. I'm thrilled to be here with you and to be moderating with my colleague a panel of experts. Just to say that these experts are part of a technical advisory group to the World Health Organization. Basically, they are advising us on how we can advance RCCE-IM, taking stock of the learnings of the recent emergencies. And the establishment of this group is actually telling us that RCCE-IM is a public health intervention based on science and is helping to mitigate and control the emergencies that we have seen growing in this region in the past years. And I will tell you in a nutshell why it is so. We know that in health emergencies, delivering health services and interventions is not enough. We need people to go and take those services and take those interventions. Just to say that what matters is not vaccines, is vaccination. And this is what RCCE-IM does. It bridges health service delivery with the access. So having said that, I would like to give the floor to Laura Woodward, who is my colleague and co-moderating this side event. Laura, the floor is yours.
Thank you. And hello, everyone. So my name's Laura Woodward. I am the Head of Risk Communications and Emergencies for the UK Health Security Agency. I'm here as the Chair of the Technical Advisory Group for RCCE-IM that Cristiana mentioned. I've been a professional communicator for 20 years for my sins. And I can tell you, just as Cristiana said, RCCE-IM is a critical public health intervention. At the start of an emergency, it's often the fastest, the first and the only lever we have at our disposal to start making interventions. But as we saw in the pandemic, it's not enough for us to just have amazing amounts of science, data, knowledge and understanding. Without being able to communicate that properly, it's worthless. If our audiences don't trust us, they just won't take our advice. So it's really important that we have to know our audiences, we have to understand our communities, and we have to know how to make the case with each different group for them to take action. We can never take their support for granted. We must always work on this support of trust and partnership, particularly for the vulnerable and the underserved. And that doesn't just take place when emergencies happen. We have to do that all the time. We can't just pick people up and drop them. We have to make sure that we are building those relationships and sustaining them. So we have some great speakers who are joining us on the video today to share some insights for you. The first up is Audra Diers-Lawson, who's a professor in risk and crisis communication at Kristiania University College in Norway. And then following her is Professor Richard Amlôt. He's a colleague of mine from the UK Health Security Agency. He's a behavioural scientist. He has a particular specialism in communicating with the public in emergencies. So, video, please.
I'll begin with a bold statement. During public health emergencies, good risk communication, community engagement, and infodemic management saves more lives than medical interventions alone. I live with an engineer, and I know that how most technical experts view the role of communication. While they're solving problems, we are talking about them. However, in the next few minutes, my objective is simple: to demonstrate that excellence in communication always improves large-scale medical interventions. Historically, communication campaigns have always improved the reach and impact of medical interventions, ranging from global campaigns about HIV, breast cancer awareness, and vaccination. They do this by improving the awareness of health issues, countering misleading information, improving efficacy beliefs, and giving people better ways to deal with and engage with public health practitioners. The COVID-19 pandemic also provided the most tangible evidence of the importance of effective RCCE-IM, that is risk communication, community engagement, and infodemic management. In a project evaluating the role of communication in the European COVID response, I reviewed more than 230 articles and focused on an 11-country pan-European comparison of best practices during the pandemic. When I compared the relative death and hospitalization rates, the best performing countries had 6 themes in their communication strategy. First, positive messaging is simply better than negative messaging. More specifically, positive messaging focuses on improving self and response efficacy in the medical interventions, and negative messaging, including things like blame shifting, or using fear as a key tactic, is simply less effective. Second, messaging that manages uncertainty improves public health response. Public health emergencies create uncertainty. By focusing on messaging that clarifies, defines, and describes, it helps people to understand why particular behaviors are being recommended. Third, successful messaging encourages citizen engagement. When publics feel like their voices are being heard, they feel like they're included in the decision-making, they're much more likely to accept the recommendations. Fourth, public trust in institutions is absolutely essential. The higher the trust is in the environment, the more likely people are to follow through with recommendations. Most people in most countries want to use official sources of information first. Fifth, good communication is tailored to specific populations. Within countries, the most successful communication responses were those tailored to different demographics, especially the vulnerable populations. And sixth, coordinating the communication leads to better outcomes. The better the alignment between agencies, government, and public health, and influencers, the more successful the communication is likely to be. Now, can we point to some empirical examples of countries where communication was generally recognized as being effective in these cross-national comparisons? Absolutely. The Netherlands and Portugal were great case studies in effective communication because they used cross-platform methods of delivery that were highly adapted to very diverse populations. Moreover, we can say that Norway, Denmark, and Finland all had highly successful engagement strategies. However, one of the challenges in these cross-national comparisons is both the cultural and the fact that many countries enacted different policies and different medical interventions. So if we really want to look at the power of effective communication, we should look for a comparison where culturally very similar countries took very similar courses of action, but had significantly different communication approaches. For this, the UK serves as an excellent point of comparison, in particular a direct communication comparison in the strategies across the pandemic that my colleagues and I found and have published, where communication practices was one of the best explanations for the better overall death rates in Scotland compared to England. Throughout the pandemic, Scotland's communication strategy embraced most of the 6 best practices with a very simple approach. First, explain and model what people should do. Second, tell them why they should do that. Third, use 2-sided argumentation, recognizing questions, criticisms, and concerns, and using respected experts to do this. And fourth, use simple and clear branding to make the campaign recognizable. We know it's simply true that across time, good communication saves lives. We have a lot of evidence from the COVID-19 pandemic that gives specific recommendations about how to communicate better. But we have a number of countries that also serve as strong exemplars for enacting these strategies. In any public health emergency, there are 2 challenges: solving the material health problem, and that's where the scientists come in, and then ensuring that the public is on board, and that's where the communication experts come in.
Late in 2022, the Collins English Dictionary chose permacrisis, a word meaning an extended period of instability and insecurity, as their word of the year. This seemed fitting as the 3rd year of a global pandemic came to a close. 2023 has seen some shift in focus, but no let-up in the need for a sustained public health response to a range of ongoing emergencies. Our collective experience of the last 3 years has taught us much about the impact a global pandemic can have on society. Our planning assumptions have been challenged and in some cases broken by the realities of the response. Critically, it's brought into stark relief the different effects a large-scale outbreak can have on our diverse communities. So Audra has told us that good risk communication, community engagement and infodemic management are vital to saving lives and mitigating the impacts of a public health emergency. My task in the next few minutes is to tell you that the best strategies and interventions are evidence-led. Being evidence-led means we base our decisions, strategies and interventions on data, research and factual information rather than on assumptions, anecdotes or unverified information. Evidence in this context can take a variety of forms, but all seek to develop our understanding of our communities, their contexts and constraints, and the impacts of a new health hazard on daily lives and behaviour. It's an iterative learning process. When we evaluate our communication strategies and public health interventions, we generate new evidence for what works and what doesn't, and we must continue to develop our practice using these insights. I'd like to tell you about some of our recent experiences of using evidence. Early in the COVID-19 pandemic, we stood up multidisciplinary scientific advisory groups. Rapid evidence synthesis by these groups was a vital tool, and it recognised that much of the evidence that can support our early action and communications is generated before an emergency. We can be actively seeking to understand what the likely impacts are of new risks and threats, and how our communities might respond to emergencies before they occur. We initiated new mixed methods studies that sought to rapidly develop our insight into how the epidemic was affecting attitudes and behaviours. Population surveys are an often utilised and valuable tool for this purpose, but their immediate value is often a function of how well we've prepared to deploy them and use their results. After the swine flu pandemic, we established a sleeping study that we woke up early in 2020 and which ran throughout the COVID pandemic. We used regularly collected population survey data to develop good situational awareness of the impacts of the pandemic on behaviour change, which in turn informed risk communication and infodemic management strategies as the pandemic continued. Some of the richest insights came from the strategic deployment of community engagement initiatives and working with community-led teams. These teams shone a light on the experiences of community groups who, due to a range of cultural and socioeconomic factors, experienced the pandemic in very different ways. We deployed teams to work with communities who are experiencing so-called areas of enduring prevalence of COVID-19, where case numbers were stubbornly high. The new evidence gave us a deeper understanding of the community's needs, their values and concerns, so that we could tailor our communications and interventions to meet those needs. Sure enough, where we co-produced communications and interventions based on the new evidence that we generated together, local case numbers began to come down. We've learned that where risk communication, community engagement and infodemic management is evidence-led, it's sophisticated, empathetic and much more likely to meet the needs of our communities and populations. We need to be ready to commission and use rapid research and community engagement, be adaptable to new evidence and insights, and be transparent and accountable when the evidence tells us that change is required. This will engender trust and help us to more effectively serve the communities that will be looking to us for guidance and advice. We should build communities of practice, engage with researchers and academic teams, and recognise that risk communication, community engagement and infodemic management is most effective when it's evidence-led.
And there's some common themes between them, which as a practitioner, I'd say are really good examples of good practice and delivery. So positive messaging, scaring people into taking action is wrong. It doesn't give you very much long-term trust, and it just doesn't engender very good behaviours. Equally, we don't want to be over-reassuring if the situation doesn't call for it. So we're always trying to strike that balance. To give you an example, there's different ways that we think about presenting data. So we could say 10% of this disease has a 10% mortality rate. 1 in 10 people will die if they have this, for people who don't like percentages. Equally, you can flip that on its head. It means exactly the same when you say 90% of people who have this disease will survive. It gives people a much more positive approach to how they're understanding the information that we're giving them. Engagement, co-creation and transparency can be quite challenging to achieve when you're running at the breakneck pace of incidents, especially when they start and you're trying to work out what's going on. So it's really good to think about how you interact with different communities ahead of time, how you might cut the data, what sort of information you might need. There's an old saying that we have 2 ears and 1 mouth, and you should use them in that proportion. That applies to public health institutes as well. So you should always make sure that you are listening. Hear what people are saying to you and react to that. Don't just plough on with them, with the way you were going to act in the first place. You've got to listen and learn directly to the affected communities. People aren't made in factories. You need to understand each different set of people. You might be the scientific experts, but they're the experts in how they live their lives and whether they can actually adopt the behaviours that you're recommending to them. Any data or insight that tells a story can make a really meaningful difference. So practical examples or stories that give people what we call an aha moment, where they can see it applying to them and their lives. It can just completely transform how a non-expert audience understands what you're trying to tell them. It's not for us to dictate what people do. We have to persuade them. We have to give them the information they need to make their own decisions. I've been the recipient of a number of Richard's recommendations. It was particularly instrumental during MPOX, where we were able to combine the epi data that we were seeing with the behavioural insights, so we could really tailor the messages and hone right down to subgroups within populations, so we knew that we were saying the right things to them. We're able to engage with the right influencers as well, when we knew there were some sections of groups who weren't necessarily that keen on engaging with authority figures. As well as shaping communications, if you're properly listening to what people are telling you, it can also affect operational elements of the public health response. So if Richard were here, he would tell you that for the most part, people actually want to comply with public health measures, and sometimes their barriers aren't behavioural at all. They're actually physical barriers, they're operational barriers. They can't get an appointment. So if you've really got that two-way communication, you can properly shape your response based on the data, based on the input you're getting.
Thank you so much, Laura. You really say that very well. And I just want to add that we have published last year in October a compendium of case studies that is basically bridging together everything that we learned during the pandemic in terms of RCCE-IM. And there are 10 lessons that are speaking exactly to the point that our speakers made today. Among this lesson, there is one single element, that is RCCE-IM leads to trust. And trust is the single element that gives us the chance of increasing people's uptake and acceptance of official guidance, so that they can really support the response and speed up the control of the emergency. And I would like to tap a little bit on the points, on those principles that revolve about trust and really contribute to that. And actually, these are the same points that were mentioned by the speakers. One of them is speaking in uncertainty. It's an art of speaking in uncertainty and really setting the expectation of the audience, of the people, that as science changes, also guidance is going to change. The second is the importance of coordination to increase consistency of messages and so reduce the confusion. The third is really the two-way communication, what Richard was mentioning, the importance of social listening and evidence generation at the start of everything we do. We cannot develop any strategy, risk communication content, any messages, unless we listen to those people we want to reach. And we base these messages on their perception and their needs. And the last is a little bit what we are going to listen in the next panel, is the engagement of the influencers. I mean, those community actors that can make a difference in influencing people's decision of uptaking protective measures. So trust is a concept that is very complex, is context-specific, but we know that by applying those principles, we have pretty good chances of achieving trust everywhere. And with this, I think it's the right time to open the floor for the questions. I've seen there is something coming up in the chat, but we would like to hear from you also here in the room, whether you have any question for our speakers. Just to let you know that the speakers will be only able to type the questions in the chat, in the app, but we will be able to read them and maybe also answer some of the questions that come from you. Thank you. Is there anything coming up? This is not the end of this. We'll still have another part, but we want to take your questions for this now. Maybe we read one of the questions?
Yeah, sure. So we've had one question in to Audra. saying the lessons that you've brought here today show the centrality of RCCE-IM to all emergency efforts and call for higher commitment to it. Sorry, the questions are moving. As an expert in this field, what would you say to decision makers to convince them to sustainably invest in RCCE-IM so we're not caught unprepared when the next emergency strikes? So Audra has responded with a short and a long answer, like a true academic. The short answer is that failing to effectively communicate can literally cost lives. I think we've all seen that. The long answer is we have years of empirical evidence that effective communications-based interventions improve the adoption of self-protective behaviours and enable medical interventions to be more successful. The critical fragility that was very painfully revealed during COVID-19 was that we left our most vulnerable populations behind because different people have different communication needs. So true. Equally vital is reducing the infodemic, which reduces the effectiveness of medical advice and medical interventions.
Thank you, Laura. Is there any further question from the room? If not, we can actually go on and move to our next panel of speakers. So we have 4 speakers joining us through another recorded video. And these speakers are from universities across the European region. You know that the European region of the World Health Organization is a very wide region made up of 53 countries, including many parts of Europe, the European Union, EA, but also Eastern Europe, Central Asia. And I'm actually introducing them. I'm very happy to introduce them by alphabetical first name order. We have the Dean of Journalism and Master of Communication from the American University of Central Asia in Kyrgyzstan, Ayjana Dushmalieva. And then from Hacettepe University in Ankara in Turkey, the Professor of Public Health, Dilek Aslan. From the University of Laura Ismail Kemali in Albania, Associate Professor Fationa Camberi. And from Lusofona University in Portugal, the Associate Professor Rui Gaspar. I would like then to ask for the video, and we will listen to these 4 interventions of the next panel. Thank you.
The total population of Central Asia is 78 million people for 5 countries. Since historically Central Asia has been more about collective approach than an individualistic, the importance of crisis communication is enormous because it's very important to how society reacts, since it's influenced to each other even more strongly than in individualistic society. Also, society is quite young and active, but there is need to be a higher trust in government institution. With such input, crisis communication become most important. So from all steps for risk communication, community engagement, and infodemic management, I want to focus on identifying key audience and influence. So there is an example from Kyrgyzstan, and I would like to share with the real story. So a community leader in Kyrgyzstan, its issues an urgent call to fellow villages, how to get vaccinated. So my story about Abdujabbar Sapalbekov, who lived in a roof settlement area with his family for more than 70 years. So this is household with 5,016 inhabitants is located out of Bishkek, Kyrgyzstan's capital. And like thousands of other Kyrgyz citizens, Abdujabbar considered himself as an internal migrant. So in terms of procedures, he wasn't indicated as a citizen of Bishkek. But somehow he moved to capital mainly for economic reasons, hoping for better life. So internal migration and internal migrants, it's comprise 35% of Bishkek population. So I believe for Europe, internal migrants among European countries also very high. So Abdul-Jabbar was elected as the head of the village last year to solve social economic difficulties for his community. And his community also has the same patterns as Abdul-Jabbar. So among his activities in his role, he actively promotes COVID-19 and routine vaccination among villages. So all of these things was important because he emphasized, I believe, that vaccination can save lives. So in Kyrgyzstan and in Central Asian countries, COVID-19 vaccine has been a real challenge amid all rumors and disinformation about the vaccine. There was a resistance and myths about the starting the pandemic, and it was a part of foreign conspiracy, and also they based on cultural and religious beliefs. So to counter myths and misinformation, Abdul-Jabbar involves religious leaders to deliver sermons to remove doubts and fears as part of awareness campaign. And after detailed conversation with vaccine deniers about the importance of vaccination for their overall health, villages usually agree and accept the shot of vaccine. So Abdul-Jabbar and many others have also helped mobile immunization team organize vaccination session for his country member and encourage people to take advantage of this opportunity to be vaccinated in line with the national immunization schedule against COVID-19. Thank you.
The world is facing many threats like wars, conflicts, earthquakes, climate crisis, and others. Novel coronavirus disease pandemic has been a challenging milestone for all of us to think on the complexity of all these issues. The complexity of the problem is in close relationship with the determinants of health, like social, economical, structural, and commercial determinants. Besides many other technical improvements, the vital importance of risk communication, community engagement, and infodemic management has emerged to address and overcome all these devastating issues. While trying to overcome the influences of the pandemic like all other countries in the world, my country, Turkey, unfortunately experienced earthquakes in February 2023. Such problems caused risk communication, community engagement, and infodemic management facilities to gain momentum in the country. Before continuing, I would like to remind all the participants the definition of infodemic management. Infodemic management is the systematic use of risk and evidence-based analysis and approaches to manage the infodemic and reduce its impact on health behaviors during health emergencies. As we all know, it aims to enable good health practices throughout 4 types of activities, including listening to communities, concerns, and questions, promoting understanding of risk and health expert advices, building resilience in the community, and also engaging and empowering communities to take positive actions. So now in the following minutes, I will try to give some insights from my country, what we have done, what I have personally done to manage all these issues. After the pandemic, as medical people, we started to study infodemic management component with my colleagues. We enhanced qualitative and quantitative research concurrently on infodemic management capacity of the health staff, also among the university medical faculty students. We also worked on slight revisions within the medical education curriculum. We integrated infodemic management modules into the curriculum of the medical faculty. After our evaluations, we have been concerned that the awareness of medical students about infodemic management has improved since we have started. I know other faculties have started to implement risk communication, community engagement, and infodemic management activities into their curricula as well. Infodemic management projects also increased in number with the participation of different disciplines. National grants started to be allocated to risk communication, community engagement, infodemic management studies, including vulnerable groups like elderly people, migrants, and people who are influenced by the earthquakes after the earthquake. Public authorities used risk communication and infodemic management techniques more than prior to the pandemic. I would like to remind a detail that World Health Organization Country Office and Turkish Ministry of Health has a collaborative act, and as far as I know, they use infodemic management techniques for social listening, especially for social listening. So the NGOs, international organization activities gained momentum within the country. Public authorities used all techniques to meet the challenges, to respond to the problems of risk communication and community engagement activities. In conclusion, the attitudes and the behaviors started to change in terms of risk communication, community engagement, and infodemic management. But I would like to remind all of us, all of the participants, to just recommend what to do for improving the risk communication, community engagement, and infodemic management activities. First, we need to increase the research capacity, I guess, and increase the resources, human resources, funding opportunities, and also give priority to equity and intervene to meet diversity-based needs. And we need to shift to a transdisciplinary approach. For example, One Health approach, and define and prioritize the intersectionality as well. And we should integrate research and practice. And as a last point, we should build or empower the monitoring and evaluation systems. Thank you for listening to me.
During the COVID-19 pandemic, rumors, conspiracy theories, and false or misleading information, in particular related to vaccination, circulated at a rapid, wide, and broad scale. A focused group discussion among health managers at different levels in the healthcare system in Albania concerning the vaccination process for COVID-19 during the first booster gives an example of how well-organized strategies at all levels of the healthcare system can influence community engagement in vaccination uptake. The discussion concluded that the vaccination process for COVID-19 in Albania was accepted by all target groups of the population, resulting in higher uptake, in particular during the application of the first booster. Overall, the group agreed that the success was a result of a collaborative effort between health managers, community leaders, and the community. The engagement of the community was assured thanks to a well-organized campaign of vaccination by the authorities, prioritizing the process among the subgroups of the target population, starting with frontline health personnel and vulnerable groups of the elderly. The first mass vaccination points were created in every city, set up in the sport palaces, and subsequently other points in schools and health centers. The involvement of the community was assured through phone contact by the management committee of the vaccination, where the data, time, and place where the vaccination would be carried were provided. The two systems used for documenting the anti-COVID vaccination process were the Vaccination Information System and the e-Albania platform, where all citizens had the opportunity to access vaccination certificates at any time. Research during the pandemic has taken a big leap, but conducting studies focus on factors with an impact on improving community engagement, even of a retrospective type, must continue to provide trusted information acceptable to the population, helping them make better health decisions.
Let me start by saying that people can be what we call social sensors. Individuals and groups can detect or sense the start of a crisis, namely that the situation is not normal anymore. People, as social sensors, can also detect or sense changes in a crisis situation over time and respond to it, for example, detecting crises within crisis. By reporting on social media their perceptions, emotions, and behaviors, people give us information on this. And by collecting such evidence, we can produce specific recommendations to inform risk and crisis communication as events unfold. Let me provide an example of such social listening we did for the Portuguese Directorate General for Health between January 2020 and October 2021 during the COVID-19 pandemic in Portugal. This focused on more than 130,000 public Facebook comments to COVID-19 related publications from health authorities and news media outlets. The content of people's comments was considered a qualitative indicator of social perceptions of the crisis characteristics at a certain point in time and across time. For example, in early summer 2021, people expressed uncertainty to why the SARS-CoV-2 infections continued going up during vaccine rollouts. Let me exemplify with a few comments. Comment 1, so many vaccines and vaccinated people. Vaccines are not as effective as they say after all. Comment 2, last year without vaccines we had 200 cases on this day. It makes you think. Comment 3, so many cases, how is this possible? The vaccines are not having any effect. Such expressions of uncertainty regarding the vaccine's effectiveness made clear to the National Health Authority the necessity to promote vaccine literacy through risk communication. The key message shared then was that scientific evidence shows that vaccination effectiveness is very high, but it's not 100%. So it's expected that infections may continue to exist despite the number of people vaccinated increasing. Also, there were beliefs that the arrival of vaccines would decrease the need for protective behaviors. This highlighted the need to communicate specific information and motivate people to maintain such behaviors. For example, the key message was that with or without vaccine, protection needs to be maintained. So social listening provides us opportunities to promote resources through health literacy, maintenance, self-efficacy, for example, to cope with crisis. Above all, promoting such resources to enable resilient individuals, communities, and the society as a whole, and above all, save lives. Thank you.
And I would like maybe to pick up some of them to reflect together. We heard particularly from Kyrgyzstan about the engagement of influencers. And as I mentioned at the beginning, this is one of the critical strategies that contribute to trust. You can imagine that during the pandemic in particular, we have identified 6 main influencers that can really make a difference in the way people accept and uptake the measures. And among these influencers, religious leaders have a great, strong role. Together with them is health workers, civil society organizations, community leaders, journalists, and young people. So engaging with these influencers can really make a difference. And in Ajana's example is really engaging community leaders and religious leaders and joining hands and making sure that they outreach the people and building the trust. I also want to highlight the point that Rui made about the health literacy. Health literacy is this single element that we are all need to build for the next emergency. It's about understanding the risks our region is prone to, so it's really encouraging countries to identify those risks they are prone to and building this understanding of what these risks are and how they work with their people. But there is also another element to that. This is what I mentioned at the beginning, is understanding how science works. And there was a question before, and the question was, what are the critical skills of a spokesperson? Well, if I can mention again one single element that works and is specific to risk communication in evolving emergencies, is what I mentioned before, is speaking in uncertainty. And I want to make you an example to clarify this. We know, you are all experts, epidemiologists, public health experts, and of course we know how science works. Science evolves. And of course the guidance, the advice, the recommendation, they need to follow the evolution of the science. So it's very normal for countries, organizations to change this advice over time. What is not normal is to be criticized for that. And this was what happened during the pandemic. We all have experienced in some way criticism because of science evolution and change in guidance. So again, I want to highlight the art and the ability of speaking in uncertainty, basing everything, all our messages, information, advice, on what we know at this point in time, saying to people and mentioning very loud and clear that this is based on what we know now and can change tomorrow because science evolves. So if there is one single element that is specific in risk communication, is really the ability in speaking in uncertainty. I would like to maybe give you the floor, Laura, for some comments.
So we've all said today that there's a wealth of data and insight out there. But one huge challenge is, particularly since the pandemic, and more now, we're seeing it used negatively. So we're seeing data used as a weapon against some of the authorities' public health messages as well. So when so many countries are doing the right thing, they're trying to be transparent, publish the data and information we know and try and explain what's going on, there can also be outside interference, either deliberately or inadvertently when people are just picking up rumours and passing them on to friends and family. So whilst the scientists and professionals know that science and data themselves are open to interpretation and not always absolute, we have to be really conscious of the environment in which our information is landing. So there's scientific literacy, there's data literacy, there's health literacy. In the UK, we had a whole country talking about the R number and flattening the curve for about a year and a half. Like, that would have been unheard of 3 years ago. Just wasn't in, it wouldn't have been in a communication strategy to try and explain that level of data to people. So when we had this wealth of it, we started trying to learn how to use it quickly and authentically and transparently to help people understand what we were trying to say and how we were trying to help them as well. As Kristiana said, we should always be transparent and open about uncertainty. If you don't know something, then you must tell people. And hopefully that you will learn more as time goes on, as whether the data tells you more, whether the EPI investigations will tell you something new or different. It's foundational to creating trust and maintaining that trust. It's much better to be honest with people and then continue a conversation. It's not just a one-time hit. As all of our colleagues have said, good communication can actually help to save lives. One thing I'd add, if I may, just to the question about the skills of a good speaker. Not everyone is a good speaker, and please accept that. Like, if any of your communications people ever tell you that they're not going to put you up, don't be offended. Maybe ask for some training. We would never put anybody up who hasn't been through media training. It is a pure skill to be able to translate complex scientific information into something that the average person on the street can understand and want to do something about. We often like using doctors and scientists to get the message across. They're usually very practiced at talking to patients. People have a really good relationship with clinicians, and hearing clinical information is generally better coming from somebody who does that for a living. It also needs to be somebody who's authentic and knowledgeable and can talk in depth about the subject, but in a way that, like I say, makes it accessible and meaningful. We also try to make sure that we're always, if we're giving the public advice about something or telling them that there's a massive increase of a disease, that they can do something about it. We call it having a call to action. You can't just tell them a problem and then leave them hanging. You must always try and find something that people can do for themselves. It really helps the message sort of take life and move on. Once again, we are completely open to any questions or comments that you guys have in the room. If anything we've said or our speakers have said that's inspired thoughts from you, or any questions you've always wanted to ask about risk communications or community engagement or even infodemic management that you've never felt you could ask before. So I think we've got a few online as well. Yeah.
Do you have any questions here? I think there is a question in the room. We'll take that.
Yes, thank you. I'm working in a state health department in Germany, and one thing that really bugged me was when do I stop caring for the idiots? And we had so many emails, and there was the command from high up was, yes, we answer all the emails that the citizens send us, and you battle with resource exhaustion. Like they can, in computer terms, people can do a denial of service attack. So you get flooded with requests. And also, I can imagine that some trolls do this systematically. Just for example, there's one person in the chat, must be from outside. It's the very same person that last year was always asking these conspiracy theory crap. And that person has a certain agenda. But when you are a public health agency, when do you stop caring for that? Or where do you draw the line and say, okay, community engagement is one thing, and infodemic management, I mean, it's a bit contradicting, not contradicting, but conflicting. So where do you say,
I think this is a great question, and it taps right into one of the emerging threats that we have seen, right? The infodemic. We know perfectly that the infodemic emerged with COVID. This is not something new, something that existed before, rumors, misinformation, but with COVID is really exploded. So to answer your question directly, actually, I want to go a little bit back. I don't want to answer immediately. I just want to mention there are a number of steps that we should take as we manage the infodemic. The first step is detection. So we need to monitor through the online system, but also the offline. You mentioned community engagement. It's very important. When we think of infodemic, normally, we think online. Not only online, it also happens at the community level. So the monitoring system, online and offline, really need to go together to detect as early as possible any false narratives that are circulating. The second step is the verification. We need to verify that rumor. We need to verify that misinformation. And we do that through a number of techniques, including working with the fact checkers. We know that there are many fact-checking organizations and agencies that have been working on that and are really a great way to understand and verify these rumors. The third, and now I'm coming to your question, is the assessment. So basically, based on the information, on the false narrative, we need to decide whether we want to take action or not. And as WHO, we take this decision based on 3 elements. So I will be very schematic here. We base it on the spread of the narrative, of the false narrative, how broad it is, on the credibility of the source, I mean, how much trust the source has in the public opinion, and on the public health impact. So based on these criteria, there is a decision on whether to design a response, because as you rightly say, sometimes we don't respond, we don't react, because reacting means also steering a debate that we don't want to steer. So there are some criteria, like I mentioned, of course I'm simplifying here, but these are basically the main elements. And then we design the response. And the response can be reactive, like debunking, so addressing the false narrative through a number of techniques. You might have known the trust sandwich. Basically, the false information is closed into accurate facts, or the pre-banking, which is more proactive and is actually exposing the manipulative techniques. So this is in a nutshell, and I'm really happy if you want to get into deeper discussion, maybe also bilaterally. We are working, as we speak in WHO, we are really prioritizing infodemic management, and we are working to build an alliance at the European level to bring together all the key stakeholders at the level of the whole of society to really address this important threat. So thanks for the question. Yeah, sorry, I spoke a lot.
Yeah, and we very much do the same. We find that if you give some of the trolls oxygen, they just keep going. But if you get to a place where you can ignore them and actually focus most of your attention down the channels that the majority of the public is listening to. We've had a question from Andrea Metzela, who has asked for a bit more specifics on how we tailor campaigns to different audiences, particularly when we're looking at things like social media and traditional media channels. That social media and traditional media are very helpful, but they are not the full extent of how we communicate with people. In fact, they're a useful element, but what we find is really helpful when you know specific communities you're trying to talk to, we try to understand who their influencers are, where the information that they receive is coming from, and look at putting that down channels that go directly to them. Not everyone listens to certain news channels. Some people don't listen to the news at all. Some of my family apparently get their news from Snapchat, which is quite frightening. So it's where do people get their information, and how do we equip the people they actually listen to? Not everyone wants to hear from a public health institution. So we spend a lot of time making toolkits, we do a lot of translations, we make sure that we're hearing concerns and reservations from different types of communities so that we can actually address their questions directly to them. And again, it's back to having authentic spokespeople who can interact with them. So we'll also invest a lot of time in working with charity groups, with voluntary sector organisations, people who actually represent and might have a deeper relationship with the people who are potentially most at risk. So we focus a lot of our time on spreading the information and spreading the different ways we get information out to people. I think that's what I need to say about that, actually.
Thank you, Laura. And maybe I want just to comment 1 second on this discussion about the professional skills that are needed in this area. And definitely we have clarity in the 3 areas: risk communication, community engagement, and infodemic management, and what the skills are. And we are at this time developing curricula, working with universities to embed this curricula in faculty of medicine, public health, and communication. We are seeing that we don't need to wait that there is an emergency, and we don't need to wait that, we train health workers in these skills. So we can catch them early and go at the university level, undergraduate, postgraduate, and really educate them with these critical skills that are needed during emergency. As you remember my first point, it's not enough to deliver the services. We need to bring together those skills based on which people will access the services. And this is the RCCE-IM skills. So this is the point I wanted to make. There are many questions coming up actually in the chat, and our experts are answering. The experts, I didn't mention that, but those who you were listening to are online and are answering many, many questions. I wonder whether there is any final question that you want to ask us before we close today's side event. Yes, there is a question there. I think the mic is coming, so we can hear you clear. No worries.
So I was thinking about, because I'm very interested in infodemic management, and currently we're trying to think how to include social listening into as a supporting tool for surveillance, especially for vaccinations. And the problem is that there is no capacity currently. So there is a discussion of including it in curricula for students now, but what do we do now with the public health professionals who are working at the institutes? And it's a very niche topic, but it's very important. So how do we build capacity with what we have? Because it's something that has been coming very often.
Yeah, totally. Shall I can maybe start, and maybe Laura, you wanna tap into that. I mean, social listening. Let me repeat it. That's the start of everything we do. We cannot, in any way, intervene in a response, particularly from the point of view of risk communication, without understanding what people think, what they perceive, and what their needs are. So I really want to highlight this. Evidence generation is the start of everything. Now, your point is a very important point, and is actually something that many share. So we lack the capacity. But first of all, I want to highlight that the pandemic, in some way, has really highlighted that we need to work in this area. And this has also encouraged and stimulated the countries, governments, but also donors to invest more in this area. We need to build this capacity before the next emergency comes in. Having said that, I think we can also find different ways and also creative way and rapid way of implementing infodemic management and social listening. If you wish, you refer to health workers, or there can be the surveillance teams, or the community social workers. We can engage with them as they go out in the community and work maybe as volunteer, or the health workers, who they have this interpersonal communication with the patients. They are an amazing source of information that can be analyzed and embedded in the response. A very strong way to do that, for instance, is hotlines. Hotlines have been proven to be an amazing way, not only of providing public health advice, but also to listen based on the question that you receive. You understand what are the perceptions, what is at the top of people's mind. And hotlines are also a very good way of basically building the trust, because you basically bridge the responders with the community. So again, this is another big topic, but as I want to mention, operational research for evidence generation is needed. We cannot skip this step, but we can work together to make it rapid, accurate, and also build on the capacities that are available. Laura, I don't know whether you want to comment on this?
Yeah, I think you can recognise as well that how people's behaviours will be dictated. So they will get their social media bubbles, they will get influenced by what they see on social media, but they might not necessarily do what they see on social media. People get information from lots of different sources. I think they normally have to hear it about 3 or 4 times before they actually act on what they're hearing. So part of our role and part of what we try to do is make sure that we really get messages across to healthcare workers, because that is often where if a member of the public has a question or an uncertainty about some advice that's being given online, whether it's from us or from whether it's more misinformation, we try and make sure that we're aware of it. We've got a fair bit of monitoring in place, but like you say, it's really hard because there's just so much from everywhere. So we try and get the main narratives and just make sure that if we're hearing stuff from either medical professionals raising questions with us about what they're hearing, if we're seeing stuff online, we equip these mainly primary care clinicians with the ability to respond. So we let them know what the questions are and what the answers are, especially if it's a new disease where they don't necessarily have all the answers, like we saw with COVID, Mpox. Just try and educate that front line of health professionals so that they can help answer the questions, because people like to validate their sources. They might hear it on social, they might go to an official website, like an official government website, they might look at the news, they might talk to friends and family, they might talk to a clinician. So you try and make sure that that information proliferates so that what they're hearing from authoritative sources backs up the sort of official advice.
Thank you, Laura. I think we are at the end of the side event. I don't know whether there is a last question that anybody wants to ask. Okay, so maybe Laura, we just bring this to the end. Do you want to say a couple of words?
So thank you everyone for coming and for listening. We weren't sure how many people would come to a communications talk at an EPI conference, so thank you for joining us in the room. Hopefully some of these conversations have opened your minds up a bit to what risk communications, community engagement and infodemic management actually means, and how that can really make a difference in a public health response that you could be working on. Like I said, press releases and media coverage seem to be what people think first when they think of RCCE-IM, but it's a whole ecosystem. There is so much work that goes on from communications professionals around making sure that a public health response lands well. So to really make a proper impact, you've got to be driven by social insights, social listening, evidence and real-time epidemiology. Think about your roles and how you can help inform your communicators to really get into the detail and really provide proper information to communities so they can actually take action. And you have to always have this thing in the back of your mind that we might not always be completely right. So make sure that you're ready to adapt your interventions based on what you're seeing and what you're hearing. And the more flexible you can be, the more successful you're likely to be.
Thank you, Laura. And I also want to thank you for coming and to listening to us. And what we are trying to do here is really to position RCCE-IM at the center of emergency response and, of course, preparedness. And I would say this is a pretty unprecedented, and we are building on the momentum that has been created by the pandemic. I just want to conclude by mentioning that there will be a new regional strategy, Preparedness 2.0, proposed to member states at the next regional committee. You know that the regional committee is the big meeting annual of the World Health Organization with all the governing bodies that basically set the agenda, the health agenda for the next year. So in this Preparedness 2.0, community protection is at the center. As I mentioned, this is pretty unprecedented. I've been working in this area for the last 20 years. This is the first time that I see communities so central to a strategy, of a regional strategy. And RCCE-IM is the building block of community protection, is what really engages the community. I mean, we have been seeing here through communicated risk, targeting risk communication to different audiences, co-creation, co-designing on intervention, and definitely addressing false information. This is what RCCE-IM does, and really bridging, and I want to repeat, bridging health service delivery and access. And I think this is really the thing we cannot do without in the future. So thank you for being with us. It was really a pleasure, and thank again to our panel. We don't see them, but we know they are online. They have been watching us and answering the questions, so it was a really great time together today. Thank you, Laura.
Thank you.